Hello, dear students. So, the first question here is a 12-year-old girl. So, we have a 12-year-old girl who is undergoing treatment for diabetic ketoacidosis. So, the diagnosis is given to you. It is DKA or diabetic ketoacidosis. And we know that initial bolus of normal saline is given. So, there was an initial bolus of 0.9% saline is normal saline. And then she was started on insulin infusion. So, insulin infusion at 0.1 units per kg per hour after an hour. Several hours later, her blood glucose decreased. So, her blood glucose level decreased to 260 milligram per dl. What should be the next step in her management? Yes. So, let us see how many of you are able to answer it. Meanwhile, we discuss about DKA. So, DKA in children, how do you diagnose it? So, there has to be diabetes or hyperglycemia. So, the blood glucose more than 200 milligram per dl. There has to be acidosis. So, if you do the blood pH less than 7.3 or serum bicarbonate less than 18 millimoles per liter. And there should be evidence of ketonemia or ketonuria. That is how you diagnose DKA. Now, whenever you have diagnosed DKA in a child, remember in the management of DKA, the first thing that you do is give fluids. So, fluid first is used in the management of DKA, remember. So, fluid first. So, the first drug to be given in the management of DKA is not insulin, it is fluids. So, in the first hour after the child presents, so in the first hour, what you give is normal saline. So, we give normal saline 10 to 20 ml per kg over 1 hour. And after that, you assess the degree of dehydration based on the severity of DKA. And then you plan the rest of the dehydration correction over the next 48 hours. So, rest of dehydration correction over next 48 hours along with insulin infusion. Okay, over next 48 hours along with insulin infusion is what you do. Okay, right? Now, one very important thing to remember is you start with normal saline only. But when the serum glucose of the baby falls to around 250 to 300 milligram per dl, that is the time when we add dextrose to the fluid. So, add 5% dextrose to the fluid when the blood glucose level falls to 250 to 300 milligram per dl. Okay. So that the baby does not land up into hypoglycemia, but we need to continue the insulin infusion to take care of the ketoacidosis part, right? So this is an important information that we must remember. Now, what about the use of insulin in a child with DK? So which insulin do you use? So we use regular insulin. So we use regular insulin. When to start? So we have to start after the first hour. After first hour treatment is over. After first hour fluid treatment is over. Okay, so we gave normal saline in the first hour. After that is over, you start regular insulin infusion at the rate of 0.05 to 0.1 unit per kg per hour. So coming back to our question. So here we said there is a child with DK and her blood glucose level has now decreased to 260 milligram per dl. So once the blood glucose level has come between 250 to 300 milligram per dl, we need to add dextrose to the fluid. So what will you do? What should be the next step in her management? Increase the insulin infusion rate? No, that would cause further fall in blood glucose. We do not want that. Stop insulin therapy? No, we do not want to stop insulin therapy because until the ketoacidosis part has resolved. Add 5% dextrose to the IV fluid seems to be a plausible option. Administer an additional bolus of normal saline, not required because the child is not in shock or hypovolemia or things like that. So our best answer is option C here. So same topic DK but a slightly more trickier version which sees your application of knowledge. So moving ahead to the next question, you have a 5-year-old child with obesity. Okay, so the child is obese. Feeding difficulties in infancy. So there's a history of feeding difficulties during infancy, developmental delay, and history of behavioral issues like anxiety and obsessive compulsive disorder. Now, this developmental delay, obesity, feeding difficulties, behavioral issues, and there are small hands and dysmorphic facial features. All these are suggestive of the diagnosis of Prader-Willi syndrome, which we'll be discussing in some more detail, but a little bit about the others. So, Lawrence Moon Bardet Biedl syndrome is also a syndrome associated with obesity. So there is obesity. There is polydactyly. So there is an extra finger on the side of little finger. It is called post-axial polydactyly. It can be present in all four limbs. That means both the upper limbs, both the lower limbs. So post-axial polydactyly and retinal pigmentary changes. Retinal pigmentary changes. Right? Down syndrome, we all know the features, the flat faces. I'll show you a picture of a child with Down syndrome we'll be discussing later. So this we know, of course, is trisomy 21, which is a type of aneuploidy. And Turner syndrome we know is 45XO, which we'll be discussing subsequently. So our best answer here based on the given case scenario is Prader-Willi syndrome. Now, Prader-Willi syndrome and Angelman syndrome are two disorders where the same genes are implicated. And you have got so many questions about them in the INI-CET exam previously. So, Prader-Willi syndrome and Angelman syndrome, in both of them, the genes implicated are on the long arm of chromosome 15. So, Prader-Willi, remember P for P. So, Prader-Willi is basically due to, in any reason, if there is a loss of paternal gene expression, it will cause Prader-Willi. Now, this loss of paternal gene expression could be due to paternal gene deletion, which is the most common mechanism responsible. It could be due to maternal uniparental disomy. That means the paternal copy is not there and both the copies of that gene is coming from the mother. So normally what happens for each gene, each child gets one copy from the father, one copy from the mother. Now, this Prader-Willi syndrome is going to happen if the paternal copy or the copy coming from father gets deleted, or it gets, some imprinting defect, or the mother's copy, maternal copy becomes duplicated. So, maternal uniparental disomy. So, these are the mechanisms by which Prader-Willi syndrome can occur. And, we said there are, feeding difficulties during infancy leading to failure to thrive during infancy, and later the child has excessive hunger, hyperphagia and obesity, right? And there could be, these behavioral disorders. There could be dysmorphism in the form of almond shaped eyes, narrow bifrontal diameter, tapering fingers, short stubby fingers. There could be intellectual disabilities, hypotonia, hypogonadism, and so on. What about Angelman syndrome? So, Angelman syndrome, again the same gene, but here the maternal copy is not getting expressed. So, it is due to loss of maternal allele expression. So, remember in Angelman there is a M. So, this is due to loss of maternal allele expression. That could be due to maternal gene deletion, or again maternal imprinting defect, or paternal uniparental disomy. Again, the most common mechanism responsible is maternal gene deletion. And here these individuals are not obese, but they are happy puppets. So it's called happy puppet syndrome. So they have, happy demeanor, frequent laughter, and they could have seizures, they could have microcephaly, and so on. Right? Okay. Now, moving on to the next question, what we have here is a 10-year-old boy who presents with a 2-year history of weight gain. So there is this 10-year-old boy with a 2-year history of weight gain. His height is in the 90th percentile. So the height is pretty good. 90th percentile means good height gain. Weight is in the 95th percentile. So weight is also too much, right? And there are no developmental delays or dysmorphic features. No developmental delay or dysmorphic features. Both parents are also obese, right? And there is no history of neurological issues or chronic medication use. So, what is the most likely cause of his obesity, right? So, again, see here, there is no history of chronic medication use. So, no steroid use and all, right? And the height is pretty good, but here the parents are also obese. So, there could be some familial thing that could be going on. So it doesn't look like Cushing syndrome, because in Cushing syndrome you will get other features of increased cortisol, increased steroids in our body. Like there could be stria, there could be moon phases, hypertension, hyperglycemia, and so on. Hypothyroidism, again, here there are no other stigmata of hypothyroidism. In hypothyroidism you will also get short stature. You may get some slowing, okay, and intellectual disability if the onset was earlier, right? And there could be myxedematous facies, there could be cold intolerance, constipation, and so on, which are not there here in this case scenario. Constitutional obesity definitely seems to be the most probable answer. Constitutional or familial obesity. It is also called exogenous obesity. Here, what happens is the parents are also obese, and mostly it is related to the lifestyle factors like excessive intake of junk food, less physical activity, and so on. What about Prader-Willi syndrome? We already discussed. So there is a typical dysmorphism that you will have in Prader-Willi syndrome, and you can have hypogonadism, hypotonia, behavioral issues, right? So a lot of these things could be there in Prader-Willi syndrome. But here our best answer is constitutional obesity. Now, from a given case scenario, how do you pick up whether it is, exogenous or constitutional obesity or endogenous? Endogenous obesity is also syndromic obesity. So, syndromic or genetic kind of, okay, underlying genetic cause is usually there. Now, as in the given case scenario, exogenous or constitutional obesity, what will you find? So, you will find generalized distribution of fat, and these individuals will be normal or tall in height, tall stature. Bone age, if you look at, would be normal or advanced. There would be no dysmorphism. Mental function would be normal, and family history of obesity is common, just like the case scenario here where both the parents were obese, right? Now, endogenous obesity, on the other hand, usually it is a central kind of obesity, right? Abdominal fat is more, and there could be short stature. So, in most of these genetic causes or syndromic causes, short stature is there. Bone age is usually retarded. Dysmorphism may be present, like we saw in Prader-Willi syndrome. Mental function again may be impaired, and family history of obesity is uncommon. So that is how from a case scenario you can distinguish whether it is constitutional or exogenous obesity, or it is some syndromic or genetic or endogenous obesity. Clear? Okay. Now, moving ahead, you have a case scenario here where a 14-year-old girl presents with fatigue, weight loss, and hyperpigmentation of the skin. So there is fatigue, there is weight loss, and hyperpigmentation. She also experiences abdominal pain and orthostatic dizziness. So the child has abdominal pain, and on getting up from sitting position suddenly, there is hypotension, postural hypotension. Lab tests reveal low serum cortisol level. So low serum cortisol level, so we are sure that it is adrenal insufficiency. Now, whether it is primary, secondary, or tertiary, we have to see. It cannot be Cushing syndrome because in Cushing syndrome there is excess of cortisol. Low serum cortisols are not there, right? So it cannot be Cushing syndrome, we are sure. Now here what you are getting is you are getting low serum cortisol, and along with that you are getting elevated ACTH. So adrenocorticotropic hormone. So normally what happens? So the cortisol gives a feedback inhibition to the ACTH, adrenocorticotropic hormone secreted from your pituitary gland, right? So if the cortisol levels are low, but the pituitary gland is secreting excessive ACTH, that means the problem is at the level of adrenals. Even though excessive ACTH is there, the adrenals are not able to produce enough cortisol. So the problem here is at the level of adrenal glands. So we are sure that it is primary adrenal insufficiency, right? Because there are low serum cortisol levels, elevated ACTH levels, aldosterone levels are normal, so mineralocorticoid pathway is not affected yet. And you got hyperpigmentation, which again indicates that the problem is at the level of adrenals. ACTH levels are high, which are also stimulating the melanocytes. So let us discuss a little bit about various types of adrenal insufficiency. So primary adrenal insufficiency, we said the problem is at the level of adrenal glands. So problem at the level of adrenal glands. And why are we labeling this condition as adrenal insufficiency? We already mentioned that there is fatigue, weight loss, hyperpigmentation, abdominal pain, orthostatic dizziness due to low cortisol levels. And cortisol levels are low, but ACTH levels are high. So pituitary seems to be working fine. Okay. So this is primary adrenal insufficiency. What happens in secondary adrenal insufficiency? So secondary adrenal insufficiency, the problem would be at the level of pituitary gland. So there would be low ACTH and no hyperpigmentation. So if there is secondary adrenal insufficiency, the ACTH level secreted from pituitary would be low. And because ACTH is low, it is not stimulating the melanocytes, so there will be no hyperpigmentation. Okay? And what about tertiary adrenal insufficiency? So, tertiary adrenal insufficiency is a form of adrenal insufficiency where the problem is at the level of hypothalamus, so even above pituitary. So, at the level of hypothalamus, so this is leading to decreased production of the corticotrophin releasing hormone. And in fact, exogenous steroids, if you give, exogenous steroids, if you give, they can cause, they can lead to suppression of the corticotrophin releasing hormone, suppression of the hypothalamo pituitary tract. And suddenly, if you withdraw these exogenous steroids, the patient can land up in adrenal insufficiency. So, if you give exogenous steroids, the corticotrophin releasing hormone production decreases. Okay, and if you suddenly stop the exogenous steroids and the corticotrophin releasing hormone is also low, so pituitary will also produce less ACTH and the endogenous cortisol production is low. So the child will land up with features of adrenal insufficiency, right? Okay. So when exogenous steroids, if you are giving and suddenly stopping it, what you have is tertiary adrenal insufficiency. Clear? Okay. Now, moving on to the next question, what you have here is a 10-year-old girl with a 3-month history of unexplained weight loss. So 3-month history of unexplained weight loss is there. So 5 kgs weight loss has happened despite increased appetite. She reports feeling constantly warm, sweating excessively, and experiencing palpitations and having decreased concentration in class. On examination, she has visible neck swelling, moist skin, and fine tremors in her outstretched hands. So, all these we know are features of hyperthyroidism. All these are features of hyperthyroidism, right? So, the patient is excessively warm, then there is weight loss, unexplained weight loss is there, excessive sweating is there, palpitations is there, neck swelling or goiter is there, moist skin, fine tremors, all these are features of hyperthyroidism. Now, treatment of hyperthyroidism in children, usually the first line drug that is used is methimazole. So, methimazole is the drug of choice. In addition, we use propranolol to decrease the adrenergic symptoms because excess of thyroid hormones also stimulate the beta adrenergic receptors and you can have palpitations, you can have tremors and all that. So to decrease the adrenergic effects, we also use propranolol along with it. But the drug of choice for the treatment of hyperthyroidism in children is methimazole. Okay. And propylthiouracil is usually avoided in children due to the risk of hepatotoxicity. So, coming back to our question, what is the most appropriate initial treatment? So, we will not use propylthiouracil due to the risk of hepatotoxicity. Methimazole is the treatment of choice. Prednisolone again is not used here because we are not suspecting an immune mediated disorder. And propranolol again will help in decreasing the beta adrenergic effects, but it is as such, it will not be able to counteract the excessive thyroid hormones that are there, right? So methimazole will, decrease the excessive production of thyroid hormones. It will decrease the production of thyroid hormones, right? So that is the best answer. Moving on to the next question. So here we have a 6-week-old infant who is brought to the emergency room with symptoms of vomiting and dehydration and shock. So vomiting, dehydration and shock are there. And on physical examination, the infant's genitalia are noted to be ambiguous. So if you're getting ambiguous genitalia in an infant, right? Okay, and there is vomiting, dehydration, and shock. These are the features of salt wasting. Initial laboratory tests are revealing severe electrolyte imbalances. Which of these is most likely diagnosis and the appropriate diagnostic test to confirm it, right? So, of course, here we are dealing with CAH or congenital adrenal hyperplasia. So, CAH most commonly happens due to 21 hydroxylase deficiency. We know that, okay? So, this 21 hydroxylase deficiency has got a simple virilizing form where mainly there is ambiguous genitalia. The features of salt wasting are not there. There is a classical form where salt wasting as well as ambiguous genitalia in a female are there, right? So here in the given case scenario, what you have ambiguous genitalia also, and you have features of salt wasting and dyselectrolytemia also. So it is the classical variety of 21 hydroxylase deficiency where salt wasting is there. Let us see what happens in that, and then we come back to answer this question. So, CAH or congenital adrenal hyperplasia, we said, is most commonly due to what enzyme deficiency? It is most commonly due to 21 hydroxylase deficiency. What happens in 21 hydroxylase deficiency? So, here this enzyme is defective. So, mineralocorticoids are not getting produced and glucocorticoids are not getting produced. No glucocorticoids, so the child is in shock. No mineralocorticoid, so mineralocorticoid not there means aldosterone is not there. Aldosterone is not there, sodium and water not getting absorbed, potassium not getting excreted. So there is salt wasting, that means loss of sodium and water, and there is hyperkalemia. Now, because this mineralocorticoid and glucocorticoid pathway is not getting completed, all the metabolites are shunted to the sex steroid pathway, right? Okay. So, sex steroid pathway. So, excess of sex steroids formed, excess of testosterone formed. In a female baby, you will have ambiguous genitalia. But in a male baby, genitalia will be normal at birth. There could be some hyperpigmentation, but when this child grows up, there will be precocious puberty. So, ambiguous genitalia in a female, right? Okay. So, you're getting ambiguous genitalia in a female and salt wasting and hyperkalemia in classical or salt wasting type of 21 hydroxylase deficiency, right? Okay, classical or salt wasting variety. Okay, and what is the metabolite that will be elevated? So because this pathway is not getting completed, progesterone gets accumulated. This pathway is not getting completed, this 17 hydroxyprogesterone also gets accumulated, and this 17 hydroxyprogesterone is used as a metabolite for screening for 21 hydroxylase deficiency. So coming back to our question, so what is the most likely diagnosis and most appropriate test to confirm it? So 21 hydroxylase deficiency with simple virilizing form. No, this is not simple virilizing form because you're getting vomiting, dehydration, shock, and you're getting electrolyte imbalances. So it's not just simple virilizing. 21 hydroxylase deficiency with salt wasting form appears to be correct. Elevated 17 hydroxyprogesterone level also is correct. So our B appears to be our answer, but let us read through the other options. Non-classical 21 hydroxylase deficiency measurement of 17 OHP levels before and after ACTH stimulation, no. So ACTH stimulation test is used in cases of adrenal insufficiency, not in CAH. Okay. 11 hydroxylase deficiency and we do hydrocortisone alone, no. In 11 hydroxylase deficiency, you can get ambiguous genitalia in females, but there'll be hypertension along with it, right? So our best answer here is B. Why do you get hypertension in 11 beta hydroxylase deficiency? Let us see. So 11 beta hydroxylase deficiency is here. You can see, okay? So the mineralocorticoid and glucocorticoid pathway are not getting completed till the end. But the substances that are formed in excess do have mineralocorticoid and glucocorticoid effect. So deoxycorticosterone is formed in excess because pathway is not able to go beyond that. So this will be formed in excess. And this has got mineralocorticoid effect. So excess of sodium and water will be absorbed. So there will be hypertension. Okay. So there will be no shock, no salt wasting. So excess of sodium and water will be absorbed. Excess of potassium will be excreted. So there will be hypokalemia. Okay. And what will happen? Excess of sex steroids will still be produced. So excess of testosterone. So there will be ambiguous genitalia in a female. Ambiguous genitalia in a female. So this is what happens in 11 beta hydroxylase deficiency. So let us write down. So ambiguous genitalia in a female. If it is with salt wasting and dehydration, we suspect 21 hydroxylase deficiency. While if it is with hypertension, we suspect 11 beta hydroxylase deficiency. So 11 beta hydroxylase deficiency, right? Now, what will happen if you are getting, 3 beta hydroxysteroid dehydrogenase deficiency? If this enzyme is defective, this enzyme is common to all the three pathways. So, no mineralocorticoids, no glucocorticoids, no sex steroids are produced. So, no mineralocorticoid, no glucocorticoid, so there will be salt wasting and dehydration. Salt wasting and dehydration. Dehydration, okay? And shock. And what will happen? No sex steroid produced. In the absence of any sex steroid, the default genitalia is female. So you will have even a male genitalia will look like a female's. So you will have a under-virilized male. Under-virilized male. Clear? Is it clear? The concept is clear, I hope, right? And if you have, this 17 hydroxylase deficiency, what will happen? So if there is this 17 hydroxylase deficiency, this enzyme is deficient, what will happen? Excess of mineralocorticoids will be produced. So there will be hypertension. So 17 hydroxylase deficiency, there will be hypertension. And because no sex steroids are produced, so what will happen? Hypertension and under-virilized male. Clear? So depending on what exactly is the case scenario is the enzyme defect. Okay. So let us write down. So if you're getting an under-virilized male, that means the sex steroids are not getting produced adequately. And salt wasting and dehydration means mineralocorticoid, glucocorticoid also not getting produced adequately, sex steroid also not getting produced adequately. All three pathways are affected. Which enzyme defect? So it is 3 beta hydroxysteroid dehydrogenase deficiency. Clear? If you're getting a under-virilized male with hypertension, then it is 17 hydroxylase deficiency where excess of mineralocorticoids are produced but your sex steroids are not produced. Clear? So this is CAH in a nutshell. So whatever case scenarios you're getting, you can solve easily with this knowledge. So moving ahead, you have a 3-year-old. So a 3-year-old child who presents with bowing of legs, delayed growth and poor weight gain. So bowing of legs, delayed growth and poor weight gain. So bowing of legs is a feature of rickets, and in rickets you can have failure to thrive as well. Though here the serum calcium levels are normal, phosphate level is low, high serum alkaline phosphatase. So in any condition wherever there is rickets, alkaline phosphatase levels are high. Parathormone level is normal here. In vitamin D deficiency rickets, what happens? The parathormone levels are high because normally the vitamin D levels, if they are low and hypocalcemia, if it is there, it causes a, the feedback inhibition of PTH will not be there. So PTH levels are elevated in vitamin D deficiency, but this does not appear to be the case. And there is normal 25 hydroxy vitamin D levels here. So our most likely diagnosis here would be what? So here you can mark that there is low serum phosphate and all the other features are like rickets. So you have hypophosphatemic rickets as the best answer here. You have bowing of legs, delayed growth, so they are clinical features of rickets. Elevated serum alkaline phosphatase level again is a feature of rickets, right? Hypophosphatemic rickets, the gene involved is the PHEX gene on the X chromosome and it is one of the very few disorders with X-linked dominant inheritance. Okay, right? Vitamin D deficiency is not the case here because the vitamin D levels are normal here. Again, VDDR type 1 and type 2 are not the cases here. We'll see what are the features we get in these two disorders. So, whenever in a case scenario of rickets, we get a varying combination of investigations. Looking at them, we can come to the diagnosis that why is the rickets there. Okay, let us try a few simple situations that can come. First thing that you see that in all cases of rickets, the alkaline phosphatase level is high. Clear? Okay, it is high. Now, if you're getting, serum calcium is normal or low, phosphate is normal or low, but the 25 hydroxy vitamin D3 level or the vitamin D3 level is low. Obviously, if vitamin D3 level is low, the active form of vitamin D3, active form of vitamin D3 that is 125 dihydroxycholecalciferol will also be low. And because the feedback inhibition on parathormone is gone away, so parathormone levels will be high. So all these are features of nutritional or vitamin D deficiency rickets. So the most common cause of rickets is nutritional deficiency of vitamin D. Okay, most common cause. Right? Clear? Now let us see the next case scenario. So here serum calcium and phosphate levels are low, alkaline phosphatase obviously is high. Vitamin D levels that we do normally is this 25 hydroxy vitamin D3. Vitamin D levels are normal here. So it is not, dietary deficiency of vitamin D is not there. But the active form of vitamin D is not adequate. So there is, decrease in the level of active form of vitamin D3. And for the formation of active form of vitamin D3 in the body, there are two enzymes that are required. 25 hydroxylase in the liver, 1 alpha hydroxylase in kidney. Deficiency of any of these two enzymes will lead to VDDR type 1. Vitamin D dependent rickets type 1. Okay? And the active form of vitamin D will be deficient. And feedback inhibition on parathormone is not there, so PTH levels will be high. Okay? Now, what about this case scenario where the calcium and phosphate levels are low, the vitamin D levels are normal, so it is not nutritional deficiency, and the active form of vitamin D is in excess. Still, it is not able to act, and so the calcium and phosphate levels are low. Excess of active form of vitamin D is there, but it is not able to act. So, there is resistance at the level of receptors. So, this is a condition which is VDDR type 2, which is due to resistance at the level of receptors, okay, to vitamin D. Now, the next case scenario where you get, calcium is normal, but phosphate is low. But vitamin D levels are normal, active form of vitamin D is also normal, PTH may be normal or high. So, mainly the abnormality here is phosphate is low in a child with rickets. You think of hypophosphatemic rickets as is the case here in the given case scenario. So, hypophosphatemic rickets, right? And in any child with rickets, if you are getting elevated phosphate levels, so phosphate levels are usually either normal or low. But in a child with rickets, if you're getting elevated phosphate levels, active form of vitamin D is also less. We think of renal rickets or rickets due to chronic kidney disease. So in chronic kidney disease, CKD, there is hypocalcemia and hyperphosphatemia. So that is how from a given case scenario, using the various combination of investigations provided, you can pinpoint the etiological cause responsible for the common causes of rickets. Okay. So what are the X-ray findings that we get? So what you can see here is there is cupping or the concavity. So there is cupping or the concavity. So cupping or the concavity, fraying or the irregularity. So cupping, fraying and widening of the ends of long bones. So that is called splaying. So it is called splaying, cupping, fraying and splaying of the ends of the long bones and in general decreased density of the bones. This fraying or irregularity is the earliest change to appear in rickets, right? Okay. And of course, in nutritional rickets, we treat it with vitamin D and calcium supplementation. Okay. Moving ahead to our next question, what we have here is a 4-year-old male who is brought to the hospital with swelling around the knee joint and both ankles for 3 months. So swelling around both knee joints and both ankles. So 3 joints, 3 to 4 joints. If one knee is involved, 3 joints are involved here, both knees are involved and 4 joints are involved. And there is swelling meaning arthritis and 3 months. The mother of this child notices that this happened after an episode of bacterial pneumonia, which is now cured, and explained that the swelling has stayed in these joints since the beginning. What is the diagnosis here? So, if you see, this fits in the definition of JIA also, because this child has age less than 16 years, and there is arthritis of multiple joints, and it has lasted for more than 6 weeks. So, this fits in the definition of JIA. Though, reactive arthritis also presents in a similar fashion. Now, JIA, the definition has broadened these days. So, JIA or juvenile idiopathic arthritis is a heterogeneous, group of idiopathic inflammatory disorders affecting, as we already mentioned, children younger than 16 years age, lasting 6 weeks or longer, and there has to be arthritis. There are various types of GIA. If more than 4 joints are involved, we call it polyarticular GIA. Polyarticular GIA. And in polyarticular GIA, there could be rheumatoid factor negative form or rheumatoid factor positive form. And in the rheumatoid factor positive form, you find rheumatoid nodules also, which can be on the wrist, which can be on extensor surface of various limbs. So rheumatoid nodules are usually found. In the rheumatoid factor negative type, you may get other antibodies like, ANA and all can be there, right? Now, 4 or less joints are involved, then we call it oligoarticular GIA. Oligoarticular GIA. Okay. And in oligoarticular GIA, there could be associated uveitis may be associated. Uveitis may be seen and ANA positivity may be there. ANA positivity is there, may be there. Sometimes, the GIA begins with oligoarthritis and slowly more than 4 joints are also involved. Then it becomes polyarthritis. But if it continues to be oligoarticular, then we call it persistent oligoarthritis. Okay. And if the systemic features predominate, like there is fever, rash, hepatosplenomegaly, and joint involvement comes later, then we call it systemic onset GIA. Systemic onset GIA. So they are the 3 main forms of GIA. There are various other types also which now come under its ambit, like psoriasis related, inflammatory arthritis, enthesitis related arthritis, and so on. So here we can see 3 or 4 joints are involved and it is fitting in the definition of GIA, but it is not polyarthritis. For polyarthritis, we need more than 4 joints. So 5 or more joints have to be there. It is not polyarthritis, so these 2 options are out. Systemic GIA, we are not thinking because fever, rash, hepatosplenomegaly not mentioned. So our best diagnosis here is persistent oligoarthritis, right? This could be reactive arthritis also. In reactive arthritis, usually enthesitis or tendon inflammation is also there, and HLA-B27 positivity could be there, and it usually subsides spontaneously, usually does not persist for such a long time like 3 months. Okay. So persistent oligoarthritis is the best answer here. So moving to one more similar question on this topic. So you have an 8-year-old child who is brought to the pediatrics department with a low-grade fever and swelling around both the knees, elbows, and shoulders for 5 months. So swelling around both the knees, elbows, and shoulders for 5 months is there. And there is arthritis. Arthritis is there, and knees, elbows, shoulder. Both the knees, elbows, and shoulders. So arthritis of 6 joints we have here already. Arthritis of 6 joints is already here. And it has lasted for 5 months. So more than 3 months. More than 3 months. Alright, more than 6 weeks is there. Less than 16 years age. And you have 1 or more joints. So you have 6 joints. So here our diagnosis has become polyarticular GIA. Polyarticular GIA. There is pain and swelling around the wrist as well. So now 6 what? It has become 8 joints actually. Knees, elbows, shoulder, wrist. Numerous nodules are noted on the hands. So nodules are there on the hands and over the spine. So you can see some of the nodules here, right? Numerous nodules are there, right? Okay. So nodules, we said rheumatoid nodules are usually seen in rheumatoid factor positive polyarticular GIA. So which of the following findings is associated with this disease? So asymmetrical involvement, no. Usually here we can see that both knees, both elbows, both shoulders, both wrists involved. So asymmetric joint involvement is not there. Uveitis is usually associated with oligoarticular GIA, as we already mentioned. Involvement of smaller joints, yes, to some extent it is there, but larger joints like knee, elbow, shoulders are also involved. The best answer here is positive rheumatoid factor. So remember we said rheumatoid factor positive polyarthritis has got rheumatoid nodules, right? Okay. Now, Identify this image. So I'm sure all of you can answer correctly. Yes, we all know. Very good. We all know it is anencephaly. So this is anencephaly, right? So we all know this is a severe form of neural tube defect, that is anencephaly. So what happens anencephaly? The defect happens in day 25 of fetal life. So day 25 of fetal life means the fourth week of intrauterine life, the genesis of this defect happens, and this has also been asked in MCQs previously. It is a severe form of neural tube defect which is incompatible with life. So here the scalp, the cranial bones, everything is absent and the brain is exposed to outside. It is due to the failure of closure of the anterior or the rostral neuropore, right? What is this? What about INI-encephaly, craniorachis, lysencephaly? So INI-encephaly and craniorachis are also forms of neural tube defects. Lysencephaly is a neuronal migration disorder. So you can see this, what defect is there? So here almost the entire spine is exposed to outside, right? Entire spinal cord is exposed to outside. So this is a defect which is very severe. This is craniorachis. Okay, craniorachis. And what do you see here? So here there is a defect mainly of the inion or the posterior part of the occiput, right? And it could be associated with the encephalocele, and you have a extended, hyperextended neck or a stargazing posture. Neck is practically absent. So this is a condition which is called iniencephaly. This is also a fatal form of neural tube defect. What do you see here? So, what is very striking in this image? Yes. So, normally in the brain, there are a lot of sulci and gyri. So, you get these convolutions and all normally. But can you appreciate here the brain is abnormally smooth. So, there is absence of sulci and gyri. So, this is a form of neuronal migration disorder called lysencephaly. So, this is called lysencephaly. So, or smooth brain, usually associated with developmental delay and intellectual disability, right? Now, moving ahead to our next question, we have a 3-month-old infant who is brought with a history of lethargy and poor feeding. Infant also exhibited some developmental delay, okay, developmental delay and hydrocephalus. On examination, the neurologist notes myelomeningocele. So there is lethargy, poor feeding, developmental delay, and hydrocephalus is also there. So on examination, there is myelomeningocele is there. Okay. So myelomeningocele is there and MRI is shown below. Which of the following is the most likely diagnosis? So what you see in this MRI is, there is herniation of the lower part of cerebellum in the foramen magnum, right? So you can see there is a herniation of the lower part of cerebellum in the foramen magnum. So this is Arnold-Chiari malformation. But whether it is type 1 or type 2. So let us discuss a little bit about both the types and we come back to answer this question. So Arnold-Chiari malformation. There are two main types. Type 1 is where, displacement of cerebellar tonsils into the spinal canal, and it is not associated with hydrocephalus. And, patients usually present during adolescent period with headache, neck pain, lower extremity spasticity, urinary frequency, but it is not associated with myelomeningocele. What is more important in the pediatric age group is, the Arnold-Chiari malformation type 2, where, what happens, it is usually associated with hydrocephalus and myelomeningocele. Okay, and there is, displacement of inferior vermis of part of the cerebellum, pons and medulla into the cervical canal. Okay. So coming back to our question, because here, displacement of cerebellum is there along with myelomeningocele, right? So myelomeningocele is also there. So our diagnosis becomes Arnold-Chiari malformation type 2 here, right? What is Dandy-Walker malformation? So Dandy-Walker malformation is a condition which appears like this on imaging. You can see there is cerebellar vermis or cerebellum. A large part of cerebellum is absent. And you have dilated fourth ventricle. So dilated fourth ventricle and a large part of the cerebellum is absent. So this is the Dandy-Walker malformation, a cause of obstructive hydrocephalus or non-communicating hydrocephalus, right? Okay, Dandy-Walker malformation. Hydranencephaly, what is it? So hydro means water. Hydranencephaly is a condition where bilateral cerebral hemispheres are absent and they are replaced by fluid-filled sacs. So if you put a torch over the head, trans illumination will be positive in hydranencephaly. Okay. Moving ahead, which of the following investigations are indicated in a baby found to have TSH 70 milli-international units per liter on newborn screening? So, we do newborn screening for congenital hypothyroidism, and a TSH more than 20 milli-international units per liter is said to be screen positive. And we can do it either from the umbilical cord blood. You can either take umbilical cord blood, or you can take, heel prick sample, and you have to take it beyond 48 hours of life to avoid the TSH surge. Now, what if, the screening for CH is positive? That means TSH is more than 20 milli-international units per liter. What will you do? So, we had taken these, dried blood spots on the filter paper like this. So, dried blood spots on the filter paper are taken, and you punch a hole from that. So, you punch hole from this and you test for TSH. So, you punch hole. So, if TSH is more than 20 in one of the spots, you repunch. Take another hole, repunch, and then recall the child. Okay, you recall the child, and still, if the TSH is high and T3 T4 is low, TSH is still high and the T3 T4 is low, what do? You must do ultrasound of the thyroid gland to see whether the thyroid gland has been formed properly or not. And you must do a radionuclide scan of the thyroid gland as well. Both of these should be done. Ultrasound of thyroid as well as nuclear scan to know whether thyroid dysgenesis or dyshormonogenesis is responsible for congenital hypothyroidism. And of course, you have to start thyroxine. Start thyroxine treatment. So, L-thyroxine tablets are available. Okay, you have to crush the tablet and give to the baby. Mix in the express breast milk and give to the baby. So remember, for all babies with congenital hypothyroidism, you must do both ultrasound thyroid as well as the radionuclide or nuclear scan, because the most common cause of congenital hypothyroidism is thyroid dysgenesis. That means thyroid gland has not been formed properly. And most common cause of congenital hypothyroidism in a child with goiter is thyroid dyshormonogenesis, where the thyroid gland structurally is normal, but the thyroid hormone synthesis is not taking place properly, which we'll be able to come to know by the nuclear scan to some extent. So, what will you do if the baby is found to be screen positive on newborn screening? Reconfirmation by a serum sample only? Yes, we will reconfirm, but doing that just will not suffice. You must do the further workup. So, reconfirmation by a serum sample only, followed by USG thyroid and thyroid nuclear scan if the baby is found to have congenital hypothyroidism, appears to be a reasonable answer. Reconfirmation by a serum sample only and USG thyroid gland alone is not going to help. You must do a nuclear scan also. And further investigation is not required. Start the treatment? No. Because, if you're giving thyroxine to the baby, you might have to give it lifelong, because there are some cases where it could have been transient hypothyroidism. But in conditions like thyroid dysgenesis, thyroid dyshormonogenesis, the thyroid gland has not formed properly, or thyroid hormone synthetic pathway is defective, lifelong treatment is required. So you must do further investigations to decide whether for this child can we, give treatment for say first 3 years and reassess if it is a transient cause, or if it is a cause like thyroid gland is not formed, thyroid agenesis or dysgenesis, then lifelong treatment will be required. So further investigations are definitely required to know the etiology of congenital hypothyroidism and decide about the treatment plan, right? Till what age you need to give it. Okay. So B was our best answer. Moving to the next question, you have a 14-month-old boy who presented to emergency department with a fever of 39 degrees Celsius, so significant fever, 102.2 Fahrenheit, and GTCS, generalized tonic-clonic seizure lasting 5 minutes. So a child between 6 months to 5 years age, significant fever and seizure. So our diagnosis becomes febrile seizure because the child, seizure self-resolved, return to baseline, there's no history prior seizures or neurological issues. So because there is no, shrill cry, or, there's no, meningeal sign, increased irritability or things like that, we are not thinking of meningitis here. This appears typically to be a case of simple febrile seizure. Now, how do you distinguish simple febrile seizure from complex febrile seizure? So, febrile seizure first is in a child between 6 months to 5 years of age, presence of seizure along with significant fever. Significant fever means temperature of more than 100.4 degrees Fahrenheit without any evidence of CNS infection. Without any evidence of CNS infection. Okay, and it could be simple febrile seizure or complex febrile seizure. Simple febrile seizure are generalized tonic-clonic seizures, but in complex febrile seizure, you can have focal seizures. Simple febrile seizure lasts less than 15 minutes. Complex can last 15 minutes or longer. 15 minutes or longer. Simple febrile seizure occurs only once during an episode of fever, while complex febrile seizure, there could be focal or recurrent seizures. Focal or recurrent seizures can be there, right? So remember 3 F's of complex febrile seizure: focal, 15 minutes or longer, and you know, there could be frequent or recurrent seizures. So they could be frequent or recurrent seizures, right? Okay. So coming back to our question, it is simple febrile seizure. It is not complex febrile seizure because it is GTCS. It is lasting for less than 15 minutes, and there is only one episode of seizure that is mentioned. Multiple episodes are not mentioned. It is not febrile status epilepticus. So if a seizure lasts for more than 5 minutes, we call it status epilepticus. Management of febrile seizures, nothing specific to be done in simple febrile seizure. You make the child lie down in left lateral or recovery position so that the child does not aspirate. And you may give, if the child is at home and the seizure is lasting for more than 5 minutes, you can give nasal or buccal midazolam. So midazolam sprays are available these days. You can use that, or you can use rectal diazepam. Okay, and if the child is in a hospital and the seizure is lasting for more than 5 minutes, you manage it like status epilepticus. So the first drug to be given would be lorazepam, or if not available, then midazolam. If not available, then diazepam. So status epilepticus. And remember paracetamol. Giving paracetamol will just make the child comfortable. It will not decrease the recurrence risk of febrile seizure. If a child is having simple febrile seizure again and again, you may give intermittent prophylaxis with clobazam. Intermittent prophylaxis with clobazam. What does that mean? That means that next time when the child is having, fever, you give clobazam for the first 3 days of fever and then stop. Again, few months later, the child is having fever, you give clobazam for the first 3 days of fever and then stop. So that is intermittent prophylaxis with clobazam may be given for recurrent seizures. And sometimes for complex febrile seizures, you may start antiepileptics like valproate. But for simple partial seizures, so for simple partial seizures or simple febrile seizures, no long-term antiepileptics are required. No long-term antiepileptics required. Right? So moving to our next question. Again, a question on seizure. A 7-year-old girl presents with brief episodes of staring and unresponsiveness lasting for few seconds. So this is what you see in absence seizures. Staring, inactivity, unresponsiveness, occurring multiple times a day. Her teacher reports that she often misses instructions, so daydreaming is also what they mistake it with. And the EEG shows 3 Hz spike and slow wave discharges. So 3 Hz spike and wave pattern is typically what you see in classical or typical absence seizure. And it is precipitated by hyperventilation. So you may ask the child to blow multiple times. Give a paper and ask the child to blow paper like that. So hyperventilation can precipitate this episode. So our most likely diagnosis here is typical absence seizure. It is not myoclonic seizures. In myoclonic seizure, you get jerks like this, like you get in West syndrome, infantile spasms, hips arrhythmia, and these, developmental delay. Drug of choice in West syndrome is ACTH, we know. Typical absence seizure is what you're getting here, and the drug of choice in India is valproate. In the West, ethosuximide is used. Complex partial seizure would be, Seizures where you are getting along with that, there could be impaired awareness can be there. So complex partial seizures we're not thinking of. So focal seizures with impaired awareness is the new name for that as per the latest recommendation. Atypical absence we're not thinking. So how do you differentiate typical absence from atypical absence? It can be asked for you. First, absence seizures are generalized seizures consisting of this staring, unresponsiveness, and eye flutter lasting usually for a few seconds. Typical absences have the 3 Hz spike and wave pattern on EEG, while atypical absences have 1 to 2 Hz spike and slow wave discharges. Typical absences are associated with childhood absence epilepsy and have a good prognosis, while atypical absences may be associated with head atonia and myoclonus seen in Lennox-Gastaut syndrome, and they have a poor prognosis. They are difficult to control. Okay? Now, moving ahead, you have a 2-year-old boy who has experienced 3 febrile seizures in the past 6 months, lasting about 2 to 3 minutes. He has no neurological deficits and develops normally. His parents are anxious about future episodes and request preventive treatment. So, recurrent episodes of simple febrile seizure is happening. To prevent recurrent episodes, remember we said we could give intermittent prophylaxis with clobazam, right? So, what is the most appropriate management approach for this child? So, start continuous daily phenobarbital. No, we said long-term antiepileptics are not required in simple febrile seizures. Prescribe intermittent oral clobazam during febrile illness is correct. Recommend daily valproic acid. No, valproic acid may be given in complex febrile seizures. Advise only antipyretic use during febrile illness. So remember we said paracetamol will just make the child comfortable. It will not decrease the risk of recurrences. So intermittent clobazam prophylaxis will decrease the risk of recurrence of febrile seizures. So we can use that. Okay.